Okay, so in this session, I'll be discussing about the pharmacotherapy of diabetes mellitus, one of the topic under endocrine pharmacology. Now, why diabetes is so important? Because it is one of the non-communicable disease which is present across the globe and also across India. And every home at least have one diabetic nowadays. Now, that's the reason it is highly important to treat diabetes mellitus. So in this section, I'll be dealing with how to treat this diabetes mellitus. So the topic is pharmacotherapy of diabetes mellitus. Basically, the diabetes mellitus are four in category: type 1, type 2, and gestational diabetes and other varieties. Now we know how they diagnose that by simple plasma glucose and HbA1c level. And we have drugs which can be injected, or there are drugs which can be given oral. So let us see what are the types and how do you diagnose and what are the treatment aspect we have for diabetes mellitus. Now, first and foremost, diabetes mellitus types are type 1 diabetes and type 2. And we have another variety, that is pregnancy, that is called gestational diabetes mellitus. Now, another category, it is others, and in that we have maturity onset diabetes of young and drug induced diabetes and diabetes associated with cystic fibrosis. All others come here. These are rare. Now, what is common is the type 1 and type 2 diabetes, which has to be known properly. Now, here we will be mainly concentrating on the treatment of type 1 and type 2 diabetes. Now, when you manage type 1 diabetes, there are only two drugs which are approved for that. One is insulin, and one more drug that is approved is pramlintide. The other drug that is being approved is pramlintide. These are the only two drugs used for type 1 diabetes. But when you are managing a type 2 diabetic patient, they still have some insulin, and this insulin is not working properly. So that's the reason, first what we do is we tell them for diet modification to cut down the carbohydrate. Then along with that, we tell them for regular exercise. So we tell them for regular exercise, and then we prefer to give them oral agents. Now, why injectables are not accepted? Because patient has to take them regularly. Injectables are not accepted very much by the patient. So first we go with the oral agents, and then we go with the injectable ones. So there are so many injectable drugs now available, and remember, same insulin and pramlintide can also be used for type 2 diabetes also. So type 1 and type 2, the only two drugs which are approved for both type 1 and type 2 is insulin and pramlintide. But whatever the other drugs that I discussed are all approved for type 2 only. Please keep this in your mind. Now, gestational diabetes, the safest drug to treat this is still today, it is insulin. In a pregnant woman, the safest one till today is insulin. So now you understood how do we manage this in brief manner. Now, how do you diagnose this? Diagnosis is mainly given by the American Diabetes Association guidelines, and now we have 2021 guidelines. 2021 guidelines. So according to these guidelines, you will diagnose this based on one is HbA1c. If the HbA1c is more than or equal to 6.5%, or if the patient has fasting, it is called plasma glucose. So it should be plasma glucose. If that is more than 126 milligram per deciliter, or the postprandial plasma glucose. So postprandial plasma glucose, if it is more than or equal to 200 milligram per deciliter. So this has to be taken into consideration after giving a oral glucose tolerance test. That is, we give 75 gram of anhydrous glucose dissolved in water, and after 2 hours we measure this. So this is measured after 2 hours. Or another criteria is whenever you measure random plasma glucose, that is RBS, and if it is more than 200 milligram per deciliter, plus the patient should have hyperglycemic symptoms. Hyperglycemic symptoms like polyuria, polydipsia, and polyphagia, and his random checking shows that his sugar is more than 200 milligram per deciliter, then obviously these are the 4 categories through which we diagnose diabetes. The HbA1c, fasting plasma glucose, postprandial plasma glucose, or random plasma glucose. So this is what the ADA 2021 guidelines tell you. So once we are diagnosed with this, now what are the drugs available for treatment of this? Now to understand that, I will show you a diagram and we will target from there. Right. So this is a simple diagram, and in this I have represented the brain, the nephron, the intestine, adipose tissue, skeletal muscle, liver, and intestine. So I will tell you why I have represented this. Now, how does the glucose enter the body? Usually, when a person eats, he usually takes in the form of polysaccharides. He will usually take in the form of polysaccharides. So these polysaccharides enter the small intestine. There they become disaccharides, particularly the sucrose, and that will be converted into monosaccharide, that is glucose. Now this conversion from disaccharide to glucose, that is from, let us assume, sucrose to glucose, is by an enzyme called alpha glucosidase. It is by the enzyme alpha glucosidase. Now this glucose which is there, and it gets absorbed into the liver. So this gets absorbed into the liver. Now the glucose which is absorbed into the liver will be stored for future usage as glycogen. So glycogen, it is stored as glycogen. So glucose which is absorbed is stored as glycogen, or the same glucose which is there may be utilized by the tissues, and one is the skeletal muscle or the adipose tissue. So this glucose may be utilized if the person is having stress, or is walking, is doing some work, immediately requires energy. So glucose has to be shifted to the skeletal muscles. Now, what is the next thing is, whenever the glucose is there, the glucose, high glucose is also sensed whenever the glucose is high. So this is the blood vessel where the glucose is now there. Not only there it is taken up, it is also sensed by the high glucose in the blood vessel. So whenever there is high glucose, this will be sensed by the pancreas. So the high glucose is sensed by pancreas, and this starts releasing insulin. So insulin gets released by the pancreas. Now another drug, which is another substance that is released along with insulin, is a substance by the name amylin. So whenever insulin gets released, another molecule that gets released is amylin. Now this insulin release can also be affected by a channel called potassium, that is called ATP sensitive potassium channels. So these will also play a role in releasing insulin. Another discovery has been done where they have told that whenever you take the glucose oral, now oral glucose stimulate a cell called intestinal L cells, and this will release glucagon like peptide 1. So intestinal L cells, only they will stimulate this GLP-1 on oral glucose only, not on IV glucose, and this will also act on the pancreas and increases insulin release. But this GLP-1 is very short acting. It is metabolized by the DPP4 into inactive within 5 minutes. So this is one way. Now this glucose which is high can also be decreased by the control from the brain. So even the control mainly from the brain, particularly the dopamine, D2 can control this glucose activity. That is the new discovery. Now when the glucose is high, obviously this glucose which is high has to be filtered by the kidneys. So it goes into the kidney, from there it has to be filtered. Now when the glucose gets filtered, this glucose is reabsorbed back by a transporter called sodium glucose transporter 2. So this sodium glucose transporter 2 is the one which is going to reabsorb this glucose. Now the threshold for this is up to 180 milligram per deciliter. If the sugar is this much, it will get reabsorbed. But if the glucose value in the person is more than that, then the glucose goes out in urine. We call it as glucose urea. So you can diagnose this glucose urea by doing urine test, and that's why it is called madhumeha. So meha, madhu means the sweetness, meha means urine. So because glucose goes out in this. Now this is what happens. Now penultimately what is the problem is, culprit is the increase in glucose. Now what happens if the glucose is high? Let it be high. What is the problem? The problem is it will lead to complications. There are two complications because of that. One is microvascular complication. So microvascular complication like retinopathy, neuropathy, and also it causes retinopathy, neuropathy, and nephropathy. And also there will be macrovascular complication. That means increase in heart failure, stroke. So these are the complications that we call it as micro and macrovascular complications. And also in the long run, it will cause poor wound healing. So increased glucose on the long term, not today or tomorrow, it is on the long run that this microvascular complications, like it will damage the kidney, it will damage the nerves, it will damage the retina, and also it will increase the risk of heart attacks and strokes. This is the reason that this glucose has to be controlled in the normal levels. You cannot allow this glucose to be high. Now treatment of type 1 diabetes is only insulin, and another option is pramlintide. But we have variety of targets we can achieve from this diagram. So what are the targets we can achieve? I will go one by one. Now first and foremost, if the patient doesn't have insulin, obviously you supplement insulin itself. We have the animals which can give insulin. We have the recombinant DNA technology from where we can get insulin. Second, you can mimic the amylin. The third, what we can do is we can affect this ATP sensitive potassium channels. I will tell you what is the role of them. Now fourth, what we can do is this glycogen, many a times it may get metabolized, that we call it as glycogenolysis, and from there the glucose may come out. So I don't want that to come out. And we have fourth group of drugs, they are called biguanides. They affect this. So these are called biguanides. So biguanides are going to affect here. Now ATP sensitive potassium channel, it is being affected by, let me write the drug here itself. One is by sulfonylureas, and one more is by meglitinides. Now the amylin mimetic drug is none other than pramlintide. So I write it above. It is the pramlintide. So first is insulin, second is pramlintide, third is sulfonylureas and meglitinides. Fourth is the glucose output is blocked by biguanides, that is the metformin. Fifth, what we can do is A drug which acts on adipose tissue, fifth one, is an insulin sensitizer. So it will increase the sensitization of insulin in this tissue, that is adipose tissue, and the drug is pioglitazone. Pioglitazone. So that's the fifth one. So next, what we can do is we can give GLP-1 agonist. Instead of the endogenous substance, we can give the GLP-1 agonist. So this will become the sixth one. Another thing what we can do is we can block this enzyme, that is DPP4. And if you block that, obviously GLP-1 will increase. That is the seventh target. Now later they also found that you can inhibit this alpha glucosidase, so that what happens, the disaccharides cannot become glucose. That is the eighth target. Now what is the next target? The ninth target is dopamine is going to decrease early morning sympathetic discharge. So you know that sympathetic stimulation causes hyperglycemia. So that's the reason you can also use a drug which acts as D2 agonist, and the drug which acts as D2 agonist is none other than bromocriptine. So that is the ninth target. Now the 10th target is, what you can do is you can do this, you can inhibit this sodium glucose transporter. So what happens, more and more glucose goes out and the glucose level in the body comes down. That is the 10th target. Now what is the 11th one? The 11th one is there is a drug which can inhibit the glucose absorption, and the drug is called colesevelam. Colesevelam. Right? So many targets we have, and all these are used for type 2 mainly. Only insulin and pramlintide for type 1. Now later they also discovered that this glucose is absorbed from the intestine by one more, that is called sodium glucose transporter 1. So later they found out that sodium glucose transporter 1 and 2 can be inhibited. Sodium glucose transporter 1, that is in the intestine, and 1 in the kidney, can be inhibited by a drug called sotagliflozin. So this is one more target. And recently we have one more target, and that is called a PPAR gamma agonist, plus it's a PPR alpha agonist. Right. So this combination of drug is being recently approved only in India, and the drug name is saroglitazar. And where do you use this saroglitazar? PPR gamma is in for diabetes, alpha for dyslipidemia. So this is approved for any patient with diabetes mellitus with dyslipidemia. So these are the potential targets why the scientists are working on. Clear, guys? So this is what we target when we treat a case of diabetes mellitus. So just have a look, take your time, pause this video for some time, and you take your page in the rectangular manner, write all the targets. So most of the times they will ask in the exam where the drug works, what is the site of action. So everything is there in this flowchart, in this conceptual image. Okay, so you revise that, and we will start by one. First we will take up insulin, then amylin receptor agonist, and later on the other drugs. Okay, so this is the concept.